Good morning or good afternoon, depending on where you are. Thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Diabetes Insipidus, Practical Review, is presented by Dr. Luma Ghalib. Dr. Ghalib finished her medical school at the Baghdad University. After graduating, she moved with her husband to New Zealand, where she did her initial training at Auckland Healthcare, New Zealand. Dr. Ghalib finished her endocrinology training in Chicago. She then worked with Mary Washington Healthcare in Virginia as a consultant endocrinologist. Dr. Ghalib joined the Ohio State University in 2013. She has been working closely with the neurosurgery and ENT team to create the state-of-the-art skull-base and pituitary clinic. She has a special interest in treating acromegaly, Cushing's, and other pituitary disorders. She is a member of the Endocrine Society, the Pituitary Network Association, and the Pituitary Society. Thank you for your involvement in our webinar program. We appreciate you doing this for us. And there will be a brief delay as we change presenters.
Thank you, Tammy, for the kind introduction.
You're welcome. You should see on, sorry, you should see on your end to accept.
Oh, okay. You can see my screen now?
Yes, I can.
Okay, perfect. Okay. Well, thank you, Tammy, for the kind introduction. As she said, I'm Dr. Ghalib, and I'm endocrinologist, and I'm sitting here a really nice sunny day in Columbus, Ohio. I hope you all having a great day wherever you are. Today we're going to talk about diabetes insipidus. And I just realized diabetes insipidus is a lot more complicated when you're trying to explain it to somebody because it involves so many other systems apart from only the pituitary gland. So the objective of today's talk is to introduce what diabetes insipidus is. And then we're going to move on to discuss who are the people who are at risk of diabetes insipidus. And then there is a few confusing things about diabetes, as it can sound very similar to other types of diabetes. And we're going to try to differentiate between the central diabetes insipidus and the nephrogenic, which is more kidney involvement. And then we're going to talk about what other things can look like or sound or feel like diabetes insipidus, and how can we differentiate between them to get to the right diagnosis. And once we confirm it, what else can you do as a patient, what we can do as a doctor, and how can we deal with DI. So if I refer to DI, it means diabetes insipidus. So this talk is planned for anybody who do have diabetes insipidus, their families, their caregivers, for healthcare providers, if you're a physician, nurse, or MA that's a half patient with diabetes insipidus, primary care, endocrinologists, surgeons, and ICU staff, and then who's anybody who wants to know more about DI. So that's where the hardship came in. It was really hard to put it in a simple term so everybody can understand what I'm saying, but not to make it too bland and too basic. So if you see a knee slide with a couple of stretches, this means it's a bit more complicated level, and don't worry if you don't get all the details. It's just too hard. So let's start. So what is diabetes insipidus? It's the inability of the body to concentrate the urine. So that will lead to producing large amount of very dilute urine. And as a result, the body will lose a lot of fluids and will feel very thirsty to try to compensate. It usually happens if there is a problem with the hormone that help us control the fluids in our body. If it's not compensated, it can lead to risk of dehydration. diabetes insipidus, luckily overall, it's not very common. It's almost 1 in a quarter million. So, but we are interested in it because we do see quite a bit of pituitary and other conditions. So let's lay the ground straight. A lot of people, when they hear diabetes, the first thing comes to their mind is sugar, which is probably they're right, because diabetes mellitus is a lot more common than diabetes insipidus. Now we think 1 in 8, 1 in 10 people can have diabetes mellitus. So this is the condition that's more related to the sugar problem, and this is what we're going to talk about today. So let's go to the basics of the word. Diabetes just means producing too much urine. It comes from a Latin and then a Greek equivalent, diabeta, which is just going through, passing. And mellitus originally really means honey. So diabetes mellitus means passing a lot of urine that containing sweet urine, glucose, and that's what diabetes mellitus is. By contrast, diabetes insipidus means bland, without distinct quality. So diabetes insipidus means urinating a lot of bland, dilute urine. So that's where the name comes from. So the body usually produces a hormone called antidiuretic hormone, or vasopressin, and this hormone mainly works on the kidney to help us concentrate the urine and preserve water loss, and it prevents us from getting dehydrated. So what happens is, if the body feels that we are dehydrated, there will be some triggers to release the antidiuretic hormone. The antidiuretic hormones is originally produced in the neurons in the hypothalamus, which is an area, I'll show you an anatomical slide in a second, which is the area that sits on top of the pituitary gland, and that hormone gets stored in the posterior pituitary part of the gland. And once the body senses the dehydration, will produce the antidiuretic hormone that will work on the kidney to help us preserve the water to keep the balance going. So what are the triggers that stimulate the antidiuretic hormone to get released? There is something called osmoreceptors. These receptors detect how concentrated our blood is. So when the body gets too dehydrated, the serum osmolarity, and by the way, this is a blood test that we can do to measure how concentrated the blood is, that means the body is getting into mild dehydration. Or there are baroreceptors. These structures sense how much volume of the blood is in there. So if the volume goes down, if the concentration goes up, that means the body is getting dehydrated. And these are the main two triggers to stimulate the hypothalamus and then the posterior pituitary to release antidiuretic hormone. The main action of antidiuretic hormone is on the kidney to help us retain more fluid, concentrate the urine, so will prevent dehydration. In severe cases of shock, the antidiuretic hormone, the vasopressin, can work on the blood vessels to help increase the tone in the blood vessels, constrict the blood vessels, and that will bring the blood pressure up in severe trauma or shock. So the hypothalamus damage, we just said that the antidiuretic hormones is actually produced from the hypothalamus. So the hypothalamus is, there are certain part of the hypothalamus that will produce the antidiuretic hormone. I'm going to just move on to the next slide because I like pictures and will show us a nice picture. So these are the parts of the hypothalamus produce the antidiuretic hormone. So if there is any damage more north or more superior to the median eminence of the hypothalamus, then you can have DI. If there is some destruction or damage to the pituitary, that antidiuretic hormone still can get secreted. And but rarely a person have bad DI with just only a pituitary lesion. And we'll go into that one more time when I talk about the disease, because that helps us to try to figure out where the problem is when there is DI. So keep that picture in mind. This is the hypothalamus. This is the stalk of the pituitary. That's the posterior part of the pituitary. This is the interior part of the pituitary. Antidiuretic hormone gets secreted from the hypothalamus, but gets stored in the posterior pituitary and gets released to the circulation from there. If there's damage down here, the hormone still is there and can be leaked to the circulation from the portal system, and the person may not have bad DI. Okay, so what's the usual way for the, so that's why when we have only a pituitary adenoma or just a minor surgery, DI is not usual. More things that can cause DI if there is a damage to the hypothalamus. There are certain diseases that can infiltrate through the hypothalamus, like histiocytosis, neurosurgery, or if there is a big lesion in the pituitary stalk that's going all the way up to the close to the hypothalamus, that like big craniopharyngiomas that actually can cause DI. So if I see a person with only a pituitary adenoma and they have bad DI, I think twice to see what's going on. So now let's move on. We suspect DI. What would a person will have if they have problem with the antidiuretic hormone? So if they keep losing very large amount of dilute urine, then the body will sense this dehydration. They will start to have excessive thirst, what we call polydipsia. I mean, they just like to drink a lot of water. And they're going to lose all that water, and they have excessive urine volume, and we call it polyuria. And what really bothers people the most is urinating at nighttime to wake up several times at night, and that's what we call nocturia, means urinating at nighttime. And people can start passing as 3 to 20 liters a day. Anything above 3 liters, we start to call it, start to think that's too much, but it depends on how bad the DI, the symptoms can be variable. Now, if the person is not able to compensate with all the fluid, then they can start having dehydration, which is another more severe symptoms when they start to have headaches, very dry mouth, lips, dry skin, start to feel dizzy if they stand up, weak muscle cramps, and if that's not taken care of, people can get confused, and in very severe cases, they actually can collapse and have severe hypotension. So the good thing is most of people who are awake and alert and they feel thirsty, they can go ahead and just drink plenty of fluid. They'll keep urinating a lot, but they avoid being dehydrated. The problems start happening if somebody cannot feel thirsty, or they cannot communicate their thirst, or they cannot get close to water or any fluids to compensate for the dehydration. And that's when real problems start to happen in people with diabetes insipidus, and they become very dehydrated. The sodium level can start to go up, what we call hypernatremia, and in severe cases they can have seizures and get into real trouble. So who are those people who cannot keep with the fluid? If they're infants, they cannot talk, or older people with dementia or confusion. People who, there's certain very specific condition. If the disease is really destroying certain part of the hypothalamus, then it can destroy even the thirst center. So they don't even feel thirsty, and those people can get into trouble really fast. And then if somebody is confused and cannot feel thirsty, cannot talk, those are the post-operative, and that's what we see mainly in the hospital, is right after pituitary surgery, neurosurgery, and or if they have severe brain trauma that they cannot, they're too confused to actually keep up with the fluid intake. So those are the high-risk population that can get into severe dehydration with DI. The majority of awake and alert people, rarely we actually see hypernatremia or severe dehydration, because they feel thirsty and they compensate and they drink enough water, but they keep going to the bathroom a lot, urinating a lot. So I'm going to try to, it's hard to simplify things, but I'll try to divide diabetes insipidus to two categories. The central, some people call it neurogenic, some people call it cranial diabetes insipidus, is where the problem is in the synthesis or release of antidiuretic hormone. Usually it's a hypothalamic or a pituitary problem, as we've just seen in the slide and previous slides. There is something called nephrogenic diabetes insipidus, and this is not going to be the main talk of this presentation just because this is more kidney issues, but I have to mention it because it's the other half of diabetes insipidus, where the problem is actually in the kidneys. So we talked about the hormone produced in the hypothalamus, stored in the pituitary gland. We talked about the triggers that would trigger the antidiuretic hormone to be released. The kidneys will sense it, will reabsorb the water, and then dehydration and hypernatremia is prevented. If the problem is in the pituitary or the hypothalamus, we call it central DI. If the problem is in the kidneys, there is antidiuretic hormone, but the kidneys cannot sense them in a normal way or cannot be responsive to the antidiuretic hormone, that we call it nephrogenic DI. So they can present very similar, but they have completely different etiology, different causes, and even treatment is different. So this is the nephrogenic. I'll just have one slide about nephrogenic, and then the rest of the talk will be mainly about central DI. So those kidney tubules that's usually sensitive to antidiuretic hormone don't sense it, don't feel the antidiuretic hormone anymore. So the person will start to have problem reabsorbing the fluid, and they can have dehydration and DI. So the most common cause is hereditary, where there's some genetic disorder in the kidneys that sense the antidiuretic hormone. Can be X-linked, more common in males, but the most common that we see, if I'm not a pediatric endocrinologist, most of these get diagnosed early on in childhood. As an adult onset nephrogenic, the most common we see, there are certain drugs that actually block the effect of antidiuretic hormone on the kidneys, and the most common that we see is lithium. There's certain antibiotics, certain chemo can do that, and then diseases in the kidney itself, like polycystic kidney disease, medullary sponge kidney, sometimes sickle cell affect the kidneys and cause that, or there are certain cancers that can affect the kidney and cause that nephrogenic DI. Means there is antidiuretic hormone, but the kidney cannot sense it in a normal way, and the person ending up with increased urination. For the central, that's where I work most of the time because I do see pituitary patient. So there's still what we call idiopathic, means we looked for a cause, we looked for a structural cause, we couldn't find a cause, but we know it's the problem is in the antidiuretic hormone secreting. And the most common is autoimmune. There's some destruction in these cells that produce the antidiuretic hormone. Craniopharyngioma is the most single diagnosis, and that's a lesion, and usually it's in the pituitary or stalk that can affect the production and the release of antidiuretic hormone. Primary brain tumors like lymphoma, again, can infiltrate the hypothalamus and cause problems. Secondary metastasis, we don't see it a lot, but every now and then we do, especially breast cancer have a special almost like predilection to involve the pituitary stalk and can cause DI earlier on. Infiltrative disease, we just said histiocytosis, neurosarcoidosis can infiltrate the part in the hypothalamus and the upper stalk and can cause DI. Neurosurgery, I'll talk a bit more about neurosurgery and post-op DI in a sec. And then severe brain trauma can cause diabetes insipidus. So who are the people who are at risk of having central diabetes insipidus? People post-surgery, for neurosurgery especially, if they have severe head trauma. Now pregnancy, Usually, normal healthy pregnancy does not cause severe DI, but if somebody already have mild or partial DI, it actually can exacerbate the symptoms and would be first presented during pregnancy. And whoever, any of the listeners who are females who've been pregnant, they remember how many times they start to go to the urinate more often. First, because of the pressure of the uterus on the bladder, but the placental hormones actually increase the breakdown of the antidiuretic hormone. So pregnancy itself can cause like almost mild physiological DI. But if somebody already have DI and get pregnant, it will make it more obvious and will bring the symptoms up to the surface and can be noticed. So idiopathic, I just mentioned it really quickly. It is actually the most common overall across-the-board causes of DI. And as I said, idiopathic means we looked for causes, but we couldn't find a structural damage. But we think it's probably a lymphocytic infiltration to the pituitary stalk on the posterior pituitary that damage these structures. And if an MRI done early on may reveal some thickening and enlargement, but then down the road they become more atrophic. And there are certain antibodies that people can check to predict the condition, although they're not 100% sensitive or specific. When a person being diagnosed with idiopathic DI, means they have DI, they looked for a cause, they couldn't find it, and they've been labeled DI. There was a study that followed these people 20 years after diagnosis, and then down the road they actually start finding a structural cause and other causes for DI to happen, and that will show the importance of keep monitoring these people and doing intermittent imaging because something may show up down the road even if they were diagnosed as idiopathic. And actually we had a case like that, and then he had histiocytosis down a few years after the diagnosis of DI. It just was not showing on the MRI earlier on. So what about neurosurgery? In the old data showing that DI right after surgery is not uncommon, almost 10 to 20% after transsphenoidal, and very high after a big, large tumor is removed. Although the newer data with the more with the minimally invasive endoscopic surgery as versus to the microscopic surgery, people having less incidence of DI, and obviously it depends how good the surgeon is, what's the complication, how big the tumor that's removed, but across the board about 13% they will have a transient DI post-op, but the majority of it will recover, and only very small percentage, less than 3% of people, will continue to have permanent diabetes insipidus after a transsphenoidal microscopic surgery. So what are the predictive factors to develop diabetes insipidus after a surgery? And if you have a Rathke cyst or even the craniopharyngioma that we talked about, just because of the location of these lesions in comparison to the stalk, and if there is intraoperative CSF leak, and that's indicate that the surgery was more complicated, the lesion was bigger, and if there were previous surgeries done, that will increase the risk of having DI. Now, a sodium level of 145 and higher in the first 5 days after surgery have a higher predictive value of more permanent DI to happen. So that's just a predictor, and then if we see that, we may keep the patient a day or two or a bit longer to differentiate what's going to happen with diabetes insipidus before we let them go home, because we don't want somebody to come in and then after surgery and get into trouble with more symptoms, and we have missed the DI before letting them go home. What about severe head injury? The interest in head injuries is actually becoming more people are more interested to monitor these patients, especially after the combat soldiers coming back, the blunt head traumas. So we know it can affect the pituitary function with hypopit after a head injury, but DI is slightly different. It's more common in more severe head injury. So if it's with blunt head injury, overall about 12%, with penetrating head injury is a lot more common. And then the risk factors, for independent risk factor for a person to develop DI, if the Glasgow Coma Scale is like how the level of consciousness, the higher the score is, the more the worse the patient is, and if they have cerebral edema, and the head score is again a scoring system that trauma team used to describe how severe the damage and the head injury is. And the diabetes insipidus by itself, if somebody have DI after a head injury, is an independent risk factor for mortality, for death. It's almost 4 times chances they may actually die from that head injury if they have DI after that trauma. So now we know what diabetes insipidus is. We know the difference between the central and the nephrogenic. We know a bit of anatomy, where the hormone is secreted. We know how it works, what's the triggering. We now understand what the symptoms are. Now we're going to look at what other things that can look like DI, but they are not. So obviously we already talked about, so anything that may make you urinate a lot or feel thirsty a lot, obviously on the top of the list is diabetes mellitus, the sugar problem, and that's the most common actually, a lot more common than diabetes insipidus. Males, especially older male with prostate enlargement, they can have increased frequency going to urinate, but if you get a good history, they urinate small amount but frequent, just because they cannot empty the bladder completely. So that's just history taking can help you, the age, the physical exam. People have too much calcium, probably hyperparathyroidism, or whatever reason the calcium is very high. The body tries to compensate by that by making the calcium get secreted through the urine, pull a lot of water with it. People feel thirsty, so they can have symptoms very similar with feeling very thirsty and go to the bathroom a lot. And psychogenic polydipsia, or some people call primary polydipsia, are those people who just cannot stop drinking, just have a water bottle with them. Some psych illnesses can have like this disorder, and sometimes is the side effect of the psychiatric medication that make the mouth very dry, and they make the person keep drinking a lot because of the dry mouth. And in the end of the day, they'll start to urinate a lot because they need to get rid of all that extra fluid they had in. So these are the things that can look DI, but it's not diabetes insipidus. What about special condition after neurosurgery that can look like DI? So, whoever had transphenodal, they remember that nasal packing, that they cannot breathe from their nose, so they have to be mouth breathers, and that will cause dry mouth, and then person will keep drinking the fluid to get rid of the dry mouth, and then they end up having to urinate a lot. So this is expected. Some of it is expected around surgery time, but can look very similar like diabetes insipidus. So that's where you need to really be very cautious about you labeling who and with what, and before you diagnose them with DI, you really want to do a good workup and good history taking. What else can look like DI around pituitary surgery? People with acromegaly. So acromegaly is a condition that they have too much growth hormone. After a good successful surgery for acromegaly, as the growth hormone goes down, a lot of the soft tissue swelling and fluid retention start to improve, and the body get rid of the extra fluid by diuresing, and that will make the person urinate quite a bit after a successful acromegaly surgery. So that can look like clinically can look like diabetes insipidus. So you have to, again, be careful when you take a good history and see what happened and what's going on. So how do we diagnose this? So we now know there's few caveats, so we have to be careful. So how we will go around and figure out who really have DI? So it all start with really good history taking. And so the person who are high risk to start with a high clinical suspicion, somebody who just had a neurosurgery or had a brain trauma or had a big lesion on the hypothalamus, you really want to be careful because they are considered very high risk of having diabetes insipidus, as versus somebody's completely healthy, no problems, no brain, no MRI abnormality, they're just drinking a lot of water, going a lot to the bathroom. You just have to be, like, they're not considered the same when you do the workup. Again, who are our people? So from the history taking, somebody is young, you really want to think about the familial and genetic diseases that we talked about. If the condition suddenly happened, abrupt, it's more suggestive of a central pituitary hypothalamic problem. If it's very gradual, make you think about it as probably nephrogenic or the probably polydipsia that we talked about. And then anybody who all of a sudden waking 4 or 5 times at nighttime make you think they may have DI. So you really want to take them seriously. As somebody who drinks a lot during the day, go to urinate a lot during the day, but once they stop drinking at nighttime, the symptoms gets better and they start not to drink, not to urinate as much. Family history is important. Other symptoms, so if they have neurosarcoidosis or they have the primary cancer, so these will have, again, take the history, good history. What's the first testing that we did? We do check a sodium level, we do check a glucose level to make sure it's not diabetes, check a calcium, a kidney function, and a lot of times we actually check a urine osmolarity. This tells us how concentrated the urine is and a urine specific gravity, and if possible to get a bit of a quantitative urine volume. So this is easy to do in the hospital. We ask the nurses to record how much the person is taking in and how much they're getting out, but in the outpatient setting will be harder unless you have a very dedicated, motivated person that's working with you to get you a good volume measurement. Now if we're still with all the history, with all these initial testing, we're not sure, then we move on to do the notorious water deprivation test. So on paper, that will sound so easy and so perfect test. In real life, it's really not simple test to do, but it is the gold standard to figure out what's happening. So this is a special test that we actually ask the person to come to the clinic, and a lot of time we actually need to admit them, and we ask the person to stop drinking water or any fluids, and we monitor them, depending if they're a child or an adult, for 6 to 12 hours. And on that time, we're measuring the urine production hourly, and then we check frequent labs, their sodium, the urine specific gravity, and then if everything is normal, once you stop drinking, the amount of the urine will slowly start to decrease, and the urine concentration will start to pick up and the person never get dehydrated. But if there is diabetes insipidus, then the urine will keep going even if the person stopped drinking, and then people can get to dehydration. The urine specific gravity stay very low, but then the serum osmolarity, the serum concentration can start to be high, and the sodiums can start to get high, and that's signs of dehydration. So when should we stop the test when we start? So the first two, meaning the urine gets be able to concentrate normally, so we stop the test. It means the person does not have DI. They're able to concentrate the urine by just asking them to stop drinking fluid. The other three, that means the person is starting to get dehydrated, and most probably they have DI. So if the the serum osmolarity means the blood starts to get too concentrated, if the sodium starts to be high, again, early signs of dehydration, or if the person loses 5%, 3 to 5% of their weight, and they still exhibiting, still urinating quite a bit. So these are signs that the person may have DI, and we need to stop before they get dehydrated. And then we have a time limit, because some people who have partial DI, they may not get to any of the endpoint, and we have to stop it at some stage. And then to confirm, so we do a therapeutic trial. So after we stop, we actually give the person antidiuretic hormone. And then we watch their urine, how it will react to that. So if the person has central DI, once we give them antidiuretic hormone, their numbers will get much, much better. If a person have nephrogenic DI, remember the kidney one, we give them the medication and they have no response to it. And then that's how we differentiate where the problem is. So for a central DI, they come in with very dilute urine, and then we restrict their fluid, stays very dilute until we give them the antidiuretic hormone, and they able to concentrate right away. So this is central DI. For nephrogenic, you ask them not to drink, but their urine's still very dilute, and then you give them the medication and they don't have good response to it. So that's nephrogenic DI. And the people who have primary polydipsia, the ones who just cannot stop drinking fluid, once we ask them to stop and we monitor them, they're able to concentrate their urine normally. So that's how we can tell. The good thing is the majority of patients in the hospital who had neurosurgery, we really don't need to subject them to the water deprivation. I can't recall any time we had to do this test on a post-op patient. We do it for most people who were not sure what's going on, they don't have a good history, or their numbers are very confusing, and we need to document and we need to get to a really good diagnosis, and that's when we end up doing the water deprivation test. And a lot of people say, then why this whole hassle? Why don't you just check an antidiuretic hormone and see what it is? Is it high or is it low? And that will help you to find out what's happening. The problem with an antidiuretic hormone is very difficult to measure. Most of it is in the platelets rather than serum. So you can get, the commercially available test is very inaccurate and have very low sensitivity and specificity, especially when the numbers goes below 3 in a low range, then you really don't get very accurate results. And as I said, it's mainly in the platelets, so the stability of the antidiuretic hormone in the test tube is hard, especially if you're going to do a send-out. Now there is some interest in copeptin, which is a C-terminal of the hormone. People who are the endocrinologists listening in the audience, you know we do that quite a lot for the C-peptide to measure insulin. So that's more stable and easier to measure. So the same concept is for antidiuretic copeptin. So there's some interest, there's a lot of research going on to see if that will be more useful in clinical practice to help us differentiate what's happening. Now, so if a person who do not have surgery, they just come in with a diabetes insipidus, and then you confirmed it's central DI, we really want to do an MRI to figure out what's happening. So or if somebody have the symptoms of DI and they have headaches, they have some vision problem, visual field defect, double vision, seizures, you really want to do that MRI to make sure we're not missing anything. Now, I tried to not to present too many data and numbers, so I didn't do a whole case presentation, but I'm just going to give you a quick history of a person that we met a few months ago. So she's 74. She gave us history just last November. She started to have significant increased urination, especially at nighttime. So she must have a very clever primary care. So he thought about DI, he did the workup, he confirmed that she had diabetes insipidus, and he started her on medication. We'll talk about Desmopressin in a second. Her symptoms improved significantly with less urination, especially in the nighttime. But then a few months later, she started to have worsening, very weak, lost a lot of weight, very lethargic, almost fainting when she stands up. So an MRI was done. And the initial MRI did show a big, so if somebody who's looking at MRI, so that's the brain, the eye is here, the nose is here, that's the rest of the cerebrum, that's the cerebellum, that's the pituitary. So that's the optic nerve, that's the the vision nerve that's come from the eye and move all the way to the back. So this is the pituitary stalk. That's what connects the hypothalamus to the pituitary. And I should have put a normal, how normal look like, but this pituitary is big. So there is a big lesion in the pituitary. And then the stalk, again, this is a wide stalk. That's not a normal. Usually the stalk is smaller than the optic chiasm. So that's definitely a bigger stalk. And then when we move up, she actually does have a big hypothalamic lesion. So remember when we said we really think twice if we see somebody with GI, and I rarely blame it on a pituitary adenoma, especially before surgery, because even if you have a big adenoma, remember the hormone is getting secreted from the hypothalamus. So it's rarely you can have complete DI, even if you have a pituitary adenoma. But when you see DI before surgery, you worry about something happening in the stalk itself or the hypothalamus. And in this case, she had a hypothalamic lesion. The first MRI she had was not a dedicated pituitary MRI and did not show that hypothalamic lesion, although it's actually gone bigger and we are able to see it with the repeat MRI. And this case turned out to be she had lung cancer that was not diagnosed, and it has spread, and she had now lesions in the lung and lymph nodes and all that. So it's just to give you a picture that's why we don't really say, oh, pituitary adenoma, DI, that makes sense. Not really. You really want to dig deeper to find out why they have a DI, because you can miss things. So now we know the person have DI. We figure out it's central or nephrogenic, and then if they have a lesion, they have to go for surgery or not, or whatever the diagnosis is. You have to treat the primary reason if there is. But at the same time, how are we going to treat with the central DI? The majority of people, we actually do use Desmopressin. So this is an analog of antidiuretic hormone, and it's the preferred in most of the patient. Now, some people will try to do the low solute, means just ask the people to eat less salt and less protein, because all that salt need to come out in the urine, and if you eat a lot of salty urine, you'll urinate more. So that's it, like a behavioral thing that can help to control the symptoms of DI. But you don't want to overdo it, because you can end up with like low sodium level and problems, other problems. These three, the three options down here, it's really mainly for nephrogenic DI. So these agents can help the antidiuretic hormone to get released, or it enhance its effect on the kidney, or work in different ways, like for example the non-steroidal work on prostaglandin. So each one have a different mechanism that can help DI symptoms, but we rarely really use it for central, because we have good medication that replace the hormone, and that's where the problem mainly is on these people who have central DI. It's used more for nephrogenic, when the person cannot sense the antidiuretic hormone. So Desmopressin comes in 3 flavors: the subcutaneous or intravenous, and this one we usually use in the hospital, especially if we're not sure what the person have, or they have nasal packing, they cannot take oral. We give them the parenteral. And then there is the nasal spray, and then there is the pills. Now, if you look at the doses, the 1 mcg, the nasal spray, 10 times the dose of the subcutaneous or IV, and the oral, it's 0.1 milligram, which is equivalent to 100 mcg, and this is almost 10 times the dose of the nasal spray. And it's not really 1 to 10, so some people can have anywhere from 5 to 20 times more effect between the nasal and the pills, and that's why the doses is different. But then the oral absorption is not that great, and it can be affected by meals. So that's why it's not a 1-to-1 dose equivalent, so you really have to be careful, super careful, if you switch from one preparation to another. And you want to monitor carefully the response, because not everybody will respond exactly the same. But overall, nasal spray are more potent than tablets. tablets are easier to take than nasal spray. The injections are rarely used apart from the outside hospital setting. Desmopressin is safe during pregnancy if it needs to be used if needed. So what's the goal of the treatment? So in the beginning, when a person have the polyuria, especially the nocturia, means urinate, waking up several times during the night, our goal for treatment is to help with that symptoms. We try to let them sleep better at night. So we start with the nighttime doses, and once the nighttime symptoms are slightly better controlled and the urine and blood tests are better, then we start to partially control their morning symptoms during the day. And the reason why we say partially control, just because if we give too much medication during the day and we fully correct the condition, and if a person end up drinking a bit more, then they'll get more fluid retention and they can have hyponatremia. It means the blood can get very diluted, and that's a very serious condition. And most of the time, the drinking during the day is not driven by thirst in a lot of instances. We just drink coffee in the morning, drink soda or fluids with meals. So we have to be careful how much to drink, especially if we overcorrected or even fully corrected a patient. And a lot of times the people who've been untreated for a long time, they just used to drink a lot. And once you put them on the medication, you correct, then they are at risk of overcorrection. So you really want to be careful and measure the the sodium level in the blood, their urine osmolarity, urine specific gravity, each time you adjust any of the doses to make sure you're not under or over. And a lot of times it's really the symptoms help us a lot to guide our doses and how we dose the person. And then one more big thing is we've just seen the data. The majority of DI, especially post-surgery, is transient. Even after big head injury is transient. So you really want to always question the need of ongoing medical therapy. And a lot of times when I get to talk to people, you know, we all miss our doses every now and then for any medication. But the Desmopressin is one medication. If a person have complete DI, they will let you know, I still need the medication. I missed it one night and I was awake all night urinating. So the person can tell if they still need the medication or not. And sometimes we do the small withdrawal trials and just hold the pill for a couple of days before you come in so we can repeat the labs. I don't do that in severe DI, but I do it if we're tapering the dose and we're on a small dose, then we can check do they still really need it or not. I expect that DI is not going to go away. If there's a big infiltrative disease, they still have bad histocytosis or neurocycosis that's still not completely treated. They still have issues that I don't expect the DI is going to resolve any soon. So that will help us to guide our big picture. So I think I'm going to stop here to give some time for questions, and I hope you're all still awake.
That was very informative. Thank you very much. We do have some questions. I want to start with some of the early questions, which may have been answered, but if so, maybe just a little review. What are the early signs of CDI, and what is the best way to confirm early subclinical CDI?
Yeah, so we talked about the symptoms. So the main thing is the drinking during the day is really hard to tell. I still remember one of my mentors, Dr. Mary Lee Vance, she say we are the water bottle generation. So it's everybody have a water bottle and drinking a lot of fluid. So this really hard to tell from drinking a lot, urinating a lot, because that's the healthy way of doing things, is the nighttime. If somebody's waking up 3-4 times at night, especially if they try to slow down on the fluid drinking or like early in the evening, that's probably one of the alerting signs. And the testing, we talked about the blood test first to exclude other causes, and the gold standard with the water deprivation.
Okay. Can CDI be intermittent in the early stages?
Yes, most of the cases are intermittent, especially after neurosurgery. We see that a lot. I didn't mention something we call triphasic DI. So that's a common condition that can happen right after an insult to the hypothalamus and the pituitary stalk. So initially the person can have DI as the first few days, and because just there was an insult damage, and then that damage can cause a lot of release of the hormones from those hypothalamic neurons. So the person have too much antidiuretic hormone the week after. So they actually have what we call SIDH, too much antidiuretic hormone. The sodium level actually may go down. And then of the week after, the DI come back. And so that's what we call triphasic. DI, SIDH, and then DI. And then the majority of these cases may recover, but there is a certain percentage that the central DI persists. And so it's very common to be intermittent and very confusing early on in the disease process.
Okay, thank you. I have had diabetes insipidus since my original transphenol for acromegaly in 2001. In 2011, I had low sodium issues resulting in seizures. My DI and the medication was thought to contribute to this. At one time, heard of a possibility that implant meds that could regulate DI and make life more predictable. Is this on the horizon or just a myth? Any information would be helpful since my DI has become more difficult to control in the last 6 months.
Yeah, so when I see a person who's been stable on medication, because we had few cases, and then all of a sudden their DI started to, so what alerts me if they actually start to need more of the, we had a craniopharyngioma case, and she was on a minimal, like a half a tablet at nighttime, and then her symptoms start to become more often, and we had to increase the dose, and then, so that can be an early sign that something is regrowing. And indeed, it took about 6 months till we were able to see it on the MRI. The craniopharyngioma is coming back. So that's one condition. If it's on the other side, if somebody's having hyponatremia, too low sodium, that can be either a person is over-treated with desmopressin, or a lot of times is actually over drinking water. And we had actually tough cases here even at Ohio State, especially when the summertime is very hot and we're telling people always drink. So if they continue to drink only water and not other solutes like not Gatorade and all that, they can get into trouble with hyponatremia. So we have to be careful, especially in the hot weather, and avoiding dehydration is important. Regarding the implants, that's, I think, still not real time yet.
Okay, thank you. What are the specific antibodies that can be used to help identify idiopathic CDI?
Yeah, so there are multiple antibodies and they can be helpful, but reviewing the literature, unfortunately, a lot of normal people, or at least they use them as controls, had these antibodies around. So, and I'm also about 70% of the idiopathic central DI, they had these antibodies, but about 30-40% of controls, means healthy people, when they check these antibodies on them, they had it positive. So it make you think, oh, so it's helpful if you have it, but it will not 100% confirm the diagnosis and not 100% rule it out. So that's why I said it's not very sensitive or specific to make the exact diagnosis. So you need the whole picture rather than just the antibodies.
Okay. I have secondary adrenal insufficiency, ACTH, presumed after much testing to be autoimmune hypophysitis. I also have Hashimoto's and CVID immune deficiency. MRIs have shown nothing of concern. I recently had another adrenal crisis and had to give dexamethasone. With this in the past and this time, I also had severe fluid retention. Often my sodium is low. I've been told to add more salt with my diet. I have confirmed low aldosterone. Even though this is rare with secondaries, I found that electrolyte solutions helped me to lose some of the fluid I was retaining. Can you speak to this?
Yeah, that's an interesting case, although the person who had the question didn't mention if they do have diabetes insipidus or not. So we have a case with hypophysitis. So hypophysitis is there where is inflammation, lymphocytic inflammation in the pituitary gland. And these people can have all sort of pituitary deficiency, all sort of panhypopituitarism, and it can be one hormone, can be multiple, and can even involve the diabetes insipidus. So we have a case of hypophysitis with DI. So they can coexist, and then if the person has central adrenal insufficiency, obviously that's part of the hypophysitis. Having low aldosterone is usually not common in hypophysitis because that's the adrenal. That's usually more with Addison disease. That's when the adrenal gland itself is involved. Unless, which would be very rare, I've never seen a case like that, is the person having hypophysitis, means inflammation in the pituitary gland and inflammation in the adrenal glands. Which is Addison disease, and sound like the person said they have Hashimoto thyroiditis, means there is an inflammation in the thyroid gland. So these are rare conditions where there are multiple autoimmune diseases involving more than one endocrine tumor, more than one endocrine organ, and I wonder if that's what this person is having.
Okay. What about a child who bedwets still at age 10? Is this normal?
Oh, I'm not a pediatric endocrinologist, but that's so bedwetting is not uncommon. It can be, so DI can be part of the differential, so it's not normal to have bedwetting at age 10, and that, when I was reviewing the literature, that's one of the early signs of diabetes insipidus in children, because remember, children, they cannot tell us a lot, although 10-year-old can communicate the thirst and all that. But there are a lot other causes for bedwetting, like psychological, diabetes mellitus, that sugar one, that's one of their main presenting symptoms. So yes, it can be part of DI, although we just said DI is not a common condition, it's rare. So we need to rule out other more common before we think about DI.
Okay. Are there any cures for central DI that researchers are working on?
I mean, in endocrine world, when there is a hormone that's deficient, we replace it. And that's what we do for thyroid, that's what we do with insulin with diabetes, and we do have the hormone, which is Desmopressin, that we replace it. And we have good preparation. The intranasal works great, the pills works great. They are, they're not, as far as I know, they're not one of the very super expensive medication. Most people can't afford it. So that's how we treat it. If there is a deficiency in the hormone, we replace it. The main thing with DI, if there is something that's causing the hypothalamus to be destroyed, like if it's a lymphoma, if it's a neurosarcoidosis, we really need, or histiocytosis, we really need to treat the underlying disease to prevent more damage rather than just replacing the hormone.
Okay, thank you. What is a mechanism of NSAIDs and TZD diuretics for treatment of nephrogenic DI?
Yeah, that's a very good question. So it doesn't make any sense when you read it. So we're giving people NSAID. So NSAID starts for non-steroidal anti-inflammatory drugs, means Motrin, Advil. These are that we use for inflammation, for pain. So how would these work on the antidiuretic in the kidneys? Doesn't make any sense. So the proposed mechanism is the antidiuretic. So these medication work on prostaglandin, and prostaglandin can decrease the effect of antidiuretic hormone. So giving those anti-inflammatory make the kidneys more sensitive to the antidiuretic hormone available. So that's the proposed mechanism, at least that's what we think, that's how these medications work. They really don't work that great for central. I don't ever use non-steroidal for a central DI, especially if wherever you're practicing, I have the pills and the nasal sprays available. But with nephrogenic, you really don't have a lot of options to treat these people because there is antidiuretic, and giving them some more sometimes can help a bit, but usually is not as good results as we see with the central DI.
Okay, great, thank you. I am pan-hypopituitary with DI. Are the only brands of DDAVP generic now? I think there was a brand by Bar, but is it still available? And do you find that any specific generic works best in most patients?
To be honest, I deal with all sort of insurance coverage. It's not one of the medication that I have problem getting insurance to cover. There are several agents, but in practical life, I have not seen one that works better than the other agent. The nasal sprays are a lot more effective, but if somebody you have partial DI, you can over-treat easier. There are certain preparation of the nasal that come, older preparation that come in 5 mcgs, but the most commercially available is 10 mcg per spray. So if you have a very mild partial DI, you can get into trouble with over-treatment with nasal sprays. Because with the orals you can do a 0.05 and you can adjust the doses with minor changes.
Okay. After 3 pituitary surgeries, I now have DI as well as low aldosterone, hypothyroidism, and low growth hormone. Would DI or any of these affect my body temperatures? Mine is typically very low and I'm uncomfortable.
I guess the main one would be for the metabolic rate will be the thyroid. Undertreated hypothyroidism, if it's central or if it is pituitary related, can cause people to feel cold and decrease core temperatures. That would be the main one. Diabetes insipidus is not a big effect on the body temperature unless somebody have severe hypothalamic lesion. So the hypothalamus is the central control of the temperature in the body. It's the central control of our satiety, how hungry we feel. It's the master central control of how thirsty we feel. So we always say the pituitary is the master gland. In reality, it's the hypothalamus that's the real master that control pituitary, and pituitary control our other hormones. So there's very rare condition where there's severe hypothalamic lesion. So the autonomous regulation of temperature, heart rate, satiety, thirst can get affected. But that's very rare. If you have panhypopid, probably thyroid will be the main hormone that regulates your temperatures that's being affected.
Okay. Are severe headaches common in untreated DI?
I wouldn't say DI itself, but the underlying condition that caused the DI to start with. So if it is the hypophysitis can cause severe bad headaches, if there is a big craniopharyngioma with hydrocephalus, pressure building up in the brain can cause severe headache. Pituitary adenomas themselves, unless they're huge, they rarely cause severe bad headaches. So I would say the underlying cause of DI itself can cause the headache, but just the DI itself, rarely we see people complaining of the headaches as part of their symptoms.
Okay, thank you. I was diagnosed with acromegaly 20 years ago and have undergone numerous procedures, etc. Currently, I receive 2 1,000 bags of lactate ringers per week to help with hydration and absorption issues. I do not present anything on labs. It seems to be an absorption issue. Any thoughts?
Yeah, that's very unusual. Unless the side effect, I'm not sure if he mentioned or she mentioned they are on medication for acromegaly, because a lot of the medical treatment of acromegaly, like the sandostatin, the somatomilins, and all these other agents, one of the major side effects of that is GI upset, diarrhea, or gallbladder problems. That's probably the only thing I can think of that can cause diarrhea with an acromegalic person. Very unlikely DI cause diarrhea. Remember, it's urinary loss in the kidneys, not through the GI. Other possibility, if somebody unfortunately have multiple other neuroendocrine tumors, so there's some condition called MEN, multiple neuroendocrine tumor, when a person can have a pituitary tumor, which acromegaly is one of them, and they can have other neuroendocrine, mainly in the pancreas, like carcinoid syndrome. These conditions can cause bad diarrhea, GI absorption problem. So if that person who have acromegaly 20 years ago and now having diarrhea, not on medical therapy, you really want to make sure they don't have MEN and no neuroendocrine tumor in their other parts of their body.
Okay. What about TZD diuretic mechanism for action of treatment of nephrogenic DI?
TZD, there's no, you mean thiazide diuretic. TZDs are medication for diabetes, like pioglitazone, and so I think that's asking about thiazide diuretics. So thiazide diuretics, again, it's a very complicated mechanism. So the thiazide diuretics supposed to affect the sodium and the water filtered in through the kidney tubules. And the mechanism is more complicated. So the concept is if you decrease the sodium that's filtered, the absorption may get affected too. And then if there is less sodium, less fluid, then it may affect the absorption ability of that antidiuretic hormone. It's the concept of decreasing the solute in the urine that may help with the mechanism of the antidiuretic hormone. So it works on the kidney tubules with a thiazide diuretic.
Okay. I have another question. This was a person who was undiagnosed, had diabetes insipidus, but undiagnosed for a while. And she says it was a webinar that you did with us last year that encouraged her to ask her doctor, and they finally did the testing. And so she started treatment in August. And thanks you for that. And her questions are, how do we know how much water to drink and salt to have? I still drink more water than most people, but not nearly as much as she did before she was treated.
Yeah, that's probably the hardest question, and I was thinking somebody will ask me that question. It's very hard really to determine, because remember, when you haven't had, if you had DI for a long time that's not diagnosed, the person could have this habit to compensate with the fluid to make sure they don't get dehydrated, because that's how she survived all that time with no medication. Now, once the medication is on board, it will be really hard to determine how much you drink. So what we tell people, try in the beginning when they're not sure what's happening and they're trying to figure out, trying to match the ins and outs. I know that sounds crazy to do, but some people will do it, is to measure how much urine they're spilling and try to match the next day how much to drink. That's very cumbersome. Most people will, let their thirst, most people we tell them, let your thirst guide you. If you're thirsty, drink. If you're not thirsty, don't push yourself too much, because you can get fluid overloaded once you're on the right treatment. And working really closely with your endocrinologist, in the beginning, I'm probably too conservative, but I do check quite a bit of urine osmolarity, urine specific gravity, and sodium levels, because we did have people that can go fast and very sensitive to medications. So you just have to work closely and keep repeating quite a bit of lab tests until you get the labs normal with your symptoms, with how thirsty you are, until you figure out what's the happy normal for you. But keeping up with measuring urine and in and out, that's what we do in the hospital, but outpatient is really harder to do. So we tell people, let your thirst guide you to how much fluid you drink.
Great, okay. She also asks, are we susceptible to other illnesses since more of our pituitary isn't working? I have had UTIs twice this year, haven't had one in 34 years, and a fungal infection affecting my fingernails I've never had before. She says she has a big vegetable garden and sometimes forgets to wear gloves, but that's been something that's been ongoing for years, and this is just recent.
Yeah, so the diabetes insipidus itself, the antidiuretic hormone itself, really has limited effect on the overall. It's more the other pituitary hormones that may have issues, especially the cortisol, because that's our anti-inflammatory, our stress hormone. So people who are over-treated or under-treated can have problems with the immune infection. Diabetes insipidus overall does not have a big role in our immune and infection susceptibility.
Okay. Can DI cause any other symptoms such as dehydration or dizziness? I developed panhypopituitarism with adrenal insufficiency, hypothyroidism, and take desmopressin.
Mm-hmm.
Yeah, desmopressin, 0.1 milligrams, half tablet, 2 times a day. I have breakthrough urination for around 4 hours before I can take the next dose. I am having a lot of dizziness and wondering if that could be a symptom. Also, is there danger in drinking too much water during this time? I am very thirsty. If I don't drink enough, can I get dehydrated?
Yeah, so this is a very reasonable question, and we talked about it in the presentation. So yes, definitely, dehydration is one of the main serious condition with diabetes insipidus, especially if you're undertreated. There is one very interesting phenomena. I didn't mention it because I didn't want to get things too complicated. So if a person have panhypopit, they have severe adrenal insufficiency just because they don't have a lot of ACTH. Once you start replacing cortisol and once you start replacing the other hormones, the body will be not as badly dehydrated as with a person who was untreated hypoparathyroidism. Then once you replace the other hormones, that actually may bring DI symptoms to the surface. The person will still be not as dehydrated and they start to urinate more often, and the DI become more obvious after replacing the other hormones. So there's very close link with all the hormones and how they function, and you just have to be careful you're not over treating too much cortisol because that make you retain fluid. You don't want to under treat DI, that make you dehydrated. So it's a very intricate balance. That's why we call it the art of medicines, and you want a good endocrinologist who really do pituitary cases to be able to help you out to do the fine-tuning. But yes, definitely dehydration and feeling dizzy and tired can be a sign of undertreated DI. And I do get quite a bit of people tell me they have the breakthrough before the next dose. So we can do lower doses, more frequency. So I have some people that I have to give them a medication 3 times a day rather than twice a day to be able to control all their symptoms. I try to give them more during the nighttime because waking up at 3 o'clock in the morning is really hard for a patient, and that will make their next day awful. So we try to correct well for the overnight symptoms. During the day, we try slightly to be undertreated because first you can drink during the day, and I don't want to fully replace, because if you just drink a bit more than what you're supposed to, you can get into trouble with being fluid overloaded.
Okay, thank you. Is there a relationship between post-pituitary surgery spinal fluid leaks and DI?
Yeah, I mean, that's one of the predictors. Remember when we said that's one of the predictors for surgery, for people to have more permanent DI. The CSF leak itself is not causing the DI because that's cerebral fluid and that's the hormone, but this just means the surgery was extensive, the tumor itself was big, and the person who have CSF leak are considered higher risk to have permanent DI down the road.
Okay. Is it possible that some people misunderstand feeling of thirst and think they are hungry instead of sensing of thirst?
That's a good question. I guess it's I don't think it's more the confusing of sensing, it's more the hypothalamic region. I just mentioned earlier that the hypothalamus is the master control, and that's where our satiety center is, that makes us feel hungry or full. That's where our thirst center is, that makes us feel thirsty. So some of the cases depend on the pathology of what happened in that area. We get some patients who, after extensive pituitary lesions, hypothalamic lesion, they cannot feel satisfied and they end up with severe obesity just because they cannot feel full again. And that's rare, but that's where all the control centers are. And so that can be an issue that person have combined problems.
Okay. If you have DI, how much salt should you have in your diet?
Yeah, that's again that hard question. Remember I told you that's the hardest question. I really cannot determine. I would not say exact number because it depends a lot on your kidney function, on how big you are, the weather temperature where you are living, how much you're working outside or not, you're more in controlled environment. So really hard to give you an exact number. But that's how you work closely with to check the numbers. But we try to ask people not to add a lot of added salt to the diet, because even if you have controlled DI and you're on the treatment, if you're adding a lot more salt, you're going to have more symptoms of the urinary symptoms. So that's, I said, one of the second option of treatment of DI is to try to limit the salts in the body intake. But the problem, if you eliminate it altogether, you can have real problems with hyponatremia, especially if you go outside, like sweat a lot, lose a lot of salt through the sweat, then you can get real trouble with hyponatremia, low sodium levels.
Okay. I think you answered this, but I'll ask it anyway.
Very, very tentative audience. I am very impressed with all the questions and really interesting, nice questions.
I take Desmopressin in the AM and PM. My doctor suggested to maybe take half a pill in the AM and a whole pill in the PM. Is there a reason why I would need less during the day than at night? And I think you answered that.
Yeah, we answered it, and then for two reasons. One is we like to have better symptom control during the night, and second, on purpose, we try to slightly undertreat during the day so we have a bit of a leeway there not to overtreat. And that's typical practice. That's not unusual.
Okay. Taking DDAVP, I have started getting my sense of hunger and fullness back, but you said this is a function of the hypothalamus. Will correcting DI affect your satiety?
Not really. Either you have, so they are like they're both controlled by the hypothalamus, but not correcting well will improve the other one. Not usual.
Okay. If a patient with DI develops hypertension, would you recommend a decreased desmopressin dose rather than starting antihypertensive medication?
Yeah, that's a very good question, and we see that in real life. You have to be careful, and a lot of people ask me the same question but in a different way. People on hydrocortisone, because we're replacing their hydrocortisone, they start to become hypertensive. Should we decrease the dose of hydrocortisone or we treat their blood pressure? The recommendation is actually if you are hypertensive, unless you're over-treated, but if you are hypertensive and you don't have fluid retention, your sodium levels are fine, you really want to treat the hypertension just like everybody else. So hypertension is a mechanism when the blood pressure go up, and a lot of time it comes with age. As the older we get, the more incidence of hypertension, and it's not all fluid. Some of it is the blood vessels become more stiff as we get older with atherosclerosis and all that, and then that's when the blood flow inside these blood vessels, the blood pressure increase. It's just a hydrodynamic. So having hypertension can have nothing to do with fluid in the body, with DI, with hydrocortisone. Obviously, you want to make sure you're not over-treated. But if you've been on a stable dose for years, and as you get older, you start to have some high blood pressure, probably just treat it as just essential hypertension, just like everybody else.
Okay, great. That, I think, concludes our questions. There's been a lot of thank you messages and a lot of appreciation for the information that you've given. It's been another thank you very, very much. It's been very informative and very helpful, and we really appreciate you taking the time out to do this for us.
Thank you, Tammy. I enjoyed it as much as everybody else. And it was hard. I didn't know that. I didn't think DI would be as complicated, but it is a very, very complicated condition just because there's so many other things involved. It's not as simple as replacing thyroid. It's a lot more complicated than that.
Great. Yeah, we have some more messages. Very informative, very helpful, fantastic presentation. Thank you. Thank you very much. Learned a lot. I learned a lot as well. It's been wonderful. Great. Thank you, everybody, for joining us and for staying the extra time for the questions. We appreciate everybody staying tuned and listening. This concludes today's webinar presentation. We appreciate you taking the time out to join us and staying late. If we did not get a chance to answer your questions, which I think we did get a chance to answer them all, we will answer others by email. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it'll be available on our website after it's edited. The PNA wishes to thank you for participating in our webinar. There'll be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and enjoy the rest of your day. And thank you again, Dr. Ghalib.
Most welcome. Bye-bye.
Bye.